Hey Rebelian viewers, Salim Razai here. It's been a minute and I promised you guys part 3 of trauma resuscitation updates, and here today that's what we're going to cover. So as a quick reminder, part 1 was minimize iatrogenic injury. Part 2 was restore perfusion. This is part 3, which is going to be promote hemostasis, and then there's a final part 4 that's going to be control bleeding. So let's talk about promoting hemostasis. So I want to talk about this darling drug of tranexamic acid, also known as TXA. And I think the big paper that really put this on the map was the CRASH-2 trial. Now, obviously there was evidence before this, people were starting to use it, but I think this is the study that did it for most people. And this was a randomized clinical trial of over 20,000 patients, and these were trauma patients. They got randomized to TXA 1 gram over 10 minutes plus 1 gram over 8 hours versus placebo, which was saline, in the same kind of distribution, over 10 minutes and then over 8 hours. And what they ended up showing is 28-day in-hospital mortality was decreased with TXA. An absolute risk reduction of 1.5%. If you crunch the numbers, that gives you a number needed to treat of 67. Now, CRASH-3 was the follow-up to this, and this was basically looking at tranexamic acid in patients with isolated head injury. And this was also a big randomized clinical trial. This was over 12,000 patients, 175 hospitals from 29 countries. They included patients, again, with isolated traumatic brain injury within 8 hours of injury, and then later on they amended their protocol and made it less than 3 hours of injury, which I think that's what most of us are following now, is that if you're within 3 hours, that's where you're going to get the biggest bang for your buck for tranexamic acid. Again, it was the same 2 types of things that they randomized people to: tranexamic acid 1 gram over 10 minutes plus 1 gram over 8 hours, and then placebo, which was normal saline, again over 10 minutes and then again in 8 hours. And what they ended up showing is head injury related death within 28 days. There was no difference. And then they started looking at their population and they broke them down into disease severity and looked at benefit. And what they found is that patients with intermediate traumatic brain injury severity had potential for the most benefit. So patients in the low severity group basically were going to do well whether we gave them tranexamic acid or not. And then people with really bad traumatic brain injury, they were going to do poor whether we gave it or not. And the way they defined these 3 groups was a GCS of 8 or less was your high severity. A GCS of 9 to 12 was your intermediate, and then a GCS of 13 to 15 was your low. And basically what they ended up having to do is say that they narrowed down a group which kind of really decreases external validity of the study, because that's not what the study was powered for. So Cryostat 1 was a feasibility study looking to see if we could even get cryoprecipitate into patients fast enough, because the problem with cryoprecipitate is it has to be thawed, which takes time. And here's what they did. The feasibility study was about 200 patients, and what they found is that yes, we can get cryoprecipitate into patients within 90 minutes of admission, which they were able to do in 85% of their patients, but they didn't find a difference in 28-day mortality. It was a secondary outcome, not what the study was powered to. Clearly need a much, much larger trial. So Cryostat 2 was the second follow-up randomized clinical trial, which the results were just published in Critical Care Reviews at their conference, but the full publication of the manuscript isn't out. But the summary, and I'm still waiting to read the paper before I kind of really weigh in on this paper, is that empiric cryoprecipitate in patients with trauma didn't really portend any type of benefit and maybe made some harm with too much clotting. Now, when we're trying to promote hemostasis, there's some targets that we should be shooting for. So obviously in trauma patients who are bleeding, we want to target platelets of greater than 50,000. If they have a head injury or intracranial hemorrhage, then that's where we want to go for greater than 100,000. For INR, we want to target less than 2. For fibrinogen, depends what paper and what guideline you read. Some people will tell you they want it to be greater than 150. Some people will say they want it all the way up to 1,000. I think most people are shooting for over 200 milligrams per deciliter. That's what we're doing at our shop, but this could also be just protocol driven at your local institution. Calcium, we're targeting an ionized calcium of 1 to 3 millimoles per liter. The thing to remember here is that calcium chloride is going to have way more calcium in it than calcium gluconate. The way to remember is calcium chloride is 1 amp. For every 1 amp of calcium chloride you would give, 3 amps of calcium gluconate would be the equivalent amount of calcium. And just a simple kind of rough way to guesstimate this is basically for every 3 units of blood products you give, you should either give the 1 amp of calcium chloride or you should give the 3 amps of calcium gluconate. And then there's TEG and ROTEM, which I don't have available at my shop. But the thought behind this is that blood products are given so rapidly in these trauma patients that sending off standard labs, standard coagulation studies, by the time they come back, how many more units of blood products have we given them? And so is it really accurate, and are we really chasing after the right thing? And so maybe TEG or ROTEM could help here. And I was able to find a couple of things. So first, this is a infographic I made with TEG and ROTEM because I could never remember what each of the letters stood for, what was the issue, what was normal, and what did I need to replace. And so I made this. I hope it's helpful. You can find it over on the Rebel EM website. If you go to Rebel Reviews and look up TEG or ROTEM, it should pull up and there should be a PDF that you can download. The second thing I found is there was actually one randomized clinical trial asking this question: Viscoelastic hemostatic assay augmented protocols for major traumatic hemorrhage, the ITACTIC trial, a randomized control trial. And so here's what they did. So these were trauma patients getting massive transfusion protocol, and what they got randomized to wasn't a treatment, but was a test. And so that was either TEG ROTEM, which they're calling viscoelastic hemostatic assays, versus just conventional labs like PT-INR and those sorts of things. And here's what they found is that there was no difference in patients alive and free of massive transfusion at 24 hours after injury, regardless of which group you got randomized to. But the problem with this study is a ton of the patients didn't ever develop coagulopathy. So if you don't develop coagulopathy, is it really going to make that much of a difference which test you actually do? And so I'm hoping there will be a follow-up to this study with a sicker group of patients to kind of really help guide us here. So promoting hemostasis, trauma resuscitation updates part 3. So TXA, a lot of the studies were 1 gram over 10 minutes followed by 1 gram over 8 hours. I've done a separate video on why we should consider doing 2 grams as an IV bolus up front in our trauma patients that are within 3 hours of injury. For cryo, the range is really broad in terms of what we should be targeting for fibrinogen. And so my group is going for 200 or greater. I would check with your trauma surgeons and see exactly what they want. For platelets, shoot for over 50,000, but if you're concerned about intracranial hemorrhage or a brain injury, that's where we want to shoot for over 100,000. INR less than 2. Don't forget your calcium. For every 3 units of blood products you give, you're going to either give 1 ampule of calcium chloride or you're going to give 3 ampules of calcium gluconate. And then finally, TEG and ROTEM. It could help. It makes logical sense. I'd like to see more evidence for this, but for the places that have it, I'm a little bit jelly, and I hope it's useful for you. Would love to hear people's thoughts that are able to use TEG and ROTEM at their shops. So there you have it, trauma resuscitation updates part 3. I will hopefully be getting part 4 out here shortly. Please leave me your thoughts, comments, and questions. Thanks for tuning in, and until next time.